Hello everyone, this is Dr. Donald John Babu. I'm a cancer surgeon, surgical oncologist at Reliance Hospital, New Bombay. This is the second session related to the urological cancers. My first session was on kidney cancers, kidney tumors, or the renal cell carcinomas. Today we'll be discussing the bladder carcinomas, or the cancers arising from the urinary bladder, also the cancers arising from the ureter, that is a pipe connecting from the kidney to the urinary bladder, and also the pelvic calyceal system, which I've mentioned in my previous session. So tumors arising from the bladder, they are basically papillary tumors with a very unique biology, because the inner lining of the urinary bladder is very unique. So the urinary bladder is generally lined by the transitional epithelium. Now, this is an epithelium that is not found anywhere else. So the tumor arising from the bladder is also unique, which is the transitional cell carcinomas. Now this lining is also seen in the ureter, which I have mentioned is a pipe connecting the kidney to the bladder, and also the pelvic calyceal system. Now, what are the causes of urinary bladder cancers? The causes are smoking, or rather any kind of tobacco usage, because what happens is when you consume tobacco, nicotine, or smoking, these substances are concentrated in the urine and they stay in the bladder for a long time until you pass the urine. So these toxins, they irritate the lining of the epithelium, which is a transitional carcinomas. They cause injury, some kind of acidic or alkali injury, which is then subjected to repair, which is where the cancer transformation takes place. Other very rare causes of bladder cancers like leiomyosarcomas, adenocarcinomas, and I would avoid discussing them because they are very rare tumors. Now, what are the signs of bladder cancers? Generally, when you do a routine test, you would find blood in the urine. Urine is also sometimes subjected to cytology, which is observing the urine for cancer cells. When you detect these kind of tumors, you might be undergoing a cystoscopy for any other reason, and you might find a bladder tumor. Even a sonography of the abdomen can detect a bladder tumor. But generally, symptoms are pain, blood and urine. I've already discussed the causes of bladder cancer, which is mainly tobacco or nicotine or smoking related issues. In the older times, chronic infection of the bladder, stones in the bladder, which would cause chronic irritation, would also cause cancers. It was a different variety of cancers at that time. It was a squamous cell carcinoma. These tumors are very rarely seen now, because any kind of infection, pain, one generally goes to a doctor and they are treated with antibiotics. We do not see those chronic stones causing irritation and then tumors, very unlikely. So how are they picked up? How are they investigated? We generally get a CT scan done or a PET scan done to see the spread of the tumor, but generally undergoes a cystoscopy. We generally subject the urine to cytology. If we see high-grade papillary cells, we know it is transitional cell carcinomas. In an endoscopy, we generally first see how these tumors are located, how many of them are there. Once we know that there is a single tumor or multiple tumors, we then counsel the patient and tell them that these tumors need to be surgically removed. Now, when it comes to treatment, it's very straightforward. We put in a scope. These tumors are generally pedunculated tumors. They come with a stalk, and then they come with a bunched up tumor at the top. So it's like a tree. And what you need to do is you need to endoscopically initially remove the tree with its stalk and its root right from the bottom. This is done endoscopically, and one spends at least 2 to 4 hours, depending upon the size of the tumor, to slowly chip into the tumors. They can bleed and they are burnt all of that is done endoscopically. So the entire stalk and the tree with its roots are removed right from the bottom endoscopically. Now, the bladder has 4 layers. One is the epithelial layer, one is the second layer, which is the lamina propria, the third layer is the submucosa, the fourth layer is the muscularis propria, which is the proper muscle layer of the bladder, and fourth is the serosa. When we are endoscopically removing the tumor, we go up to the muscle layer to remove the tumor. Now remember, there are 2 layers of muscle. There is a small muscle layer in the lamina propria, and there is a thick muscle layer which is the detrusor muscle of the bladder. Now one has to go up to the detrusor muscle to remove the root of the tumor. Once the tumor is removed, the base of the tumor, which consists of all 3 layers, is sent for histopathology. If it is seen that the tumor is infiltrating the detrusor muscle of the bladder, it means the tumor is deep enough and simply endoscopic removal of the tumor is not possible. If the tumor lies above the muscle layer and the entire tumor is removed, it doesn't need removal of the entire bladder. Now let's consider the second part, where the tumor doesn't involve the muscle layer. Once endoscopically all the tumors in the bladder is removed, immediately at the end of the surgery, we instill mitomycin C, which is a chemotherapeutic agent, at the end of the procedure. We instill this and clamp the Foley's catheter for around 6 hours. This is generally done because while removing the tumor, it is quite possible that the tumor in the bladder has gone to different locations in the bladder and settled in the bladder wall. For this, mitomycin C is instilled and the rest of the tumor is washed up with the urine with a lot of saline injections. Once we examine the histopath report of the tumor, the patient is then subjected to 3 monthly or 6 monthly BCG instillations of the bladder, because these tumors can also be immunomodulated by injecting the bladder with BCG. Once BCG is instilled into the bladder wall, there is a lot of inflammation, and we assume that the inflammation will take care of the residual tumor. This BCG installation can vary from 1 year to 3 years. So let me repeat myself. If it is the superficial tumors of the bladder, after endoscopy, mitomycin is injected immediately, and from 1 year to 3 years, we can have BCG installations into the bladder for every 3 to 6 months. Now let's consider the option of a tumor that has gone through the detrusor muscle. In such cases, bladder removal is imperative. You cannot save the bladder. The entire bladder is removed. The lymph nodes in the pelvis are addressed. The urine is collected into something called as the ileal pouch. Now the ileal pouch is created using the small intestine. A segment of the small intestine along with its vessel is made into a one-sided cylinder. One side is stapled, other side is kept open, and the ureters are joined into this cylinder of small intestine. This is disconnected from the rest of the intestine. The rest of the intestine is joined back into continuity, and this cylinder of small intestine is then removed from the abdomen and made into a small stoma. Around the stoma, we keep a bag where the urine is collected. So the ureters then join the cylinder of small intestine where the urine is collected, and the urine comes out through a small stoma to which a bag is connected. This operation is called the radical cystectomy with an ileal conduit. So we basically make an ileal conduit, the cylinder I spoke about, from the small intestine. If the tumor is large enough, we also subject the patient to chemotherapy and radiation. Some patients are not willing to remove the entire bladder, so we give them the option of endoscopic removal of the tumor and then subjecting the patient to chemo and radiation, although it is not as effective as removing the entire bladder. So there are also options of retaining the entire bladder. It is called as the neobladder, but the indications of neobladder are very few and far in between. It is not possible to remove only a small part of the bladder and stitch it back, because in such a case the bladder becomes very small and patient is very disturbed by increased frequency of urination. I also spoke about tumors arising from the pelvic calyceal system of the kidney. In such a case, the entire kidney is removed along with the ureter and a small piece of bladder tissue. All this can be done with open surgery, robotic and laparoscopic surgery. So in short, bladder tumor, mainly smoking is responsible, or tobacco. In earlier days, stones infections were also causing bladder cancers. Transitional cell carcinomas are the most common cancers. They're diagnosed with a urine cytology or investigations like USG, cystoscopy, or a CT scan, even a PET scan. Once you diagnose them, you do an endoscopy, you remove a part of the tumor. It is examined pathologically for the depth. If the depth is superficial, endoscopic removal is sufficient. We give BCG instillation into the bladder as adjuvant therapy. If the tumor has infiltrated into the muscle wall of the bladder, the entire bladder wall needs to be removed, lymph nodes need to be cleared, and an ileal conduit needs to be made. The ileal conduit will be like a stoma on which the bag will be applied and urine will be collected. So this will end my session on bladder cancer. The next session I will speak upon penile cancers and prostate cancers. Thank you.